I reflect that if all of us were having a conversation about folate, we'd say, and our patients would say, well, of course, you need folate. We need folate before pregnancy, during pregnancy, otherwise there are terrible consequences. Of course, the point is that there are terrible consequences with folate, but much of what my colleagues have been talking about, and quite profound effects, are not dissimilar in that you can eat carnitine. That's sort of where it comes from. Gentlemen, let's have some questions.
I'm Dr. Jalad from Jordan. Well, my first question is to Dr. Gian Maria. I'm a gynecologist, but I believe that there is always a gray zone when, in cases of those unexplained infertility, when we find normal semen analysis parameters with no explanation for their infertility, and the man comes to us with an ultrasound that says that he has bilateral varicocele. When the man is totally asymptomatic, do you recommend doing the surgical management on those men with normal semen parameters for a purpose of unexplained infertility?
Yeah, the question is really interesting. There are two things that we have to say. So on one side, we should say that just the semen analysis is not enough to evaluate the fertility status of a person, first of all. On the other side, we have to say that the varicocele treatment, in accordance with guidelines, is not suggested when you have a normal status of fertility. So maybe in the future, we will have parameters that will help us giving an answer to your question. For the moment, if we want to follow the guidelines, we shouldn't suggest the treatment of this varicocele. But you have to say the story of the patient. So maybe you will do strict follow-up. You will see how the fertility will change over the months, and maybe you will take your decision in accordance with this.
Okay. I have a second question for Dr. Ghanazani. Well, I can't find the explanation for, you have mentioned in your studies that the Proxeed were given to those patients with hypothalamic amenorrhea, and thus they do have LH, and the Proxeed has elevated the LH and has increased their body mass index as well. And how this happens on those patients with PCOS with the high levels of LH and high body mass index. So, I mean, it acts in two different categories of patients in two different ways. How we find the explanation?
We need to do a little bit of attention to one fact, that nature probably is working in the easiest way than we are expecting or thinking. So the problem is that, as is in endocrinology, that you have the negative and the positive feedback made by the same amount of, by the same kind of steroid maybe, but at lower level you have the positive one, and at a higher level you have the negative one. Well, here probably when you have a completely de-set up situation with an impairment which is on one side induced by the low body weight, on the other one by high body weight, the balancing inside the hypothalamus are probably completely different. So on one side, some compounds are able to improve beta oxidation only, while on the other one, on the side of PCOS, you have also the vasoactive compounds that are probably acting, and on the other one are acting also the insulin sensitivity. Since in patients with functional hypothalamic amenorrhea, probably you know very well, the level of insulin are 1, maybe 2. These patients, as you have seen from the very preliminary data, have in the average 14. So you have patients with, in baseline conditions, also 20 of insulin. So probably in the same way, the things are acting in completely different situation, and these induce on one side the upgrade of the body weight, probably saving on the energy used for other aspects of the biology, and this is for functional hypothalamic amenorrhea. And on the other side, you have completely different steps for PCOS. We have no information on this. So we have to work on this, and probably we need, or we should need, to work on the endothelial factors. that probably might give us ideas on how such compounds are working in PCOS with insulin sensitivity highly reduced.
Could you recommend using the Proxeed for those patients with anorexia nervosa, with hypogonadotrophic hypogonadism?
On one side, yes, since as you have seen, and you can read the paper which has been issued in the last issue of Journal of Endocrinological Investigation, December 2017, it decreases amylase, and amylase is one of the indicators, together with LH, of the completely resetting of the balancing inside the pituitary and the hypothalamus in the metabolic control of functional hypothalamic amenorrhea.
In our country, I came from, we have not available Proxeed woman. Can I use, it's reasonable to use for woman Proxeed Plus?
It's a preparation completely different. I can give you a suggestion. You should combine two different products, which are nicetyl, acetyl-levo-nisethylcarnitine, and L-carnitine in the compounds, so that at least to get the same effects in terms of carnitine, if you do not have Proxeed women, and a small amount of N-acetylcysteine, which is you have to combine completely different preparations, but you might get the same result.
I have a question for Mr. Bussetto. After we treat varicocele, is it useful to continue Proxeed?
Yeah, this is exactly what I'm thinking. So the suggestion for varicocele is to make surgery. So there is the really effective treatment of varicocele. To date, we cannot say that there is any medical treatment that is able to take care about varicocele. But my personal suggestion is you take care about varicocele, you make surgery, and after making surgery, you start a course of this kind of supplementation that can last for 4 to 6 months, taking consideration that the sperm to become mature, it takes something like 90 days. So minimum 3 months of this treatment after the surgery, 6 is better. After this, you can reevaluate the fertility status of the patient. You will have a further boost on increase after the surgery. So yes, suggestion is yes.
Yes, I would like to know if you recommend to treat by Proxeed every man with oligoastenospermia. So do we continue to demand the fragmentation test or not? How can we manage that? Do we treat all men with infertility with the oligoastenospermia and without doing other tests?
So that's a great question. I don't know whether you all heard that, but the question was, okay, we're making a case for treating all men with antioxidants. How can we measure the effectiveness? Should we be measuring it, particularly with DNA fragmentation studies? Gentlemen.
The question is really strong because even the reply is strong. Because when I made my presentation, I focused a bit on the diagnosis. So nowadays, we still have big trouble making the correct diagnosis. So it doesn't make, it's not for sure that a patient that is a perfect parameters of his sperm, it will have a good fertility. So this is why we are focusing on pregnancy rate, because by the end, what people want is the child. So you can have a perfect sperm, but you won't have any child. So by the end, what can you do with your sperm? So first of all, we should try to find the best way to make a correct diagnosis. And this is the first difficulty. Second difficulty, we should try to definitively say that supplementation and antioxidants are able to help in the fertility. Third point, we should keep the balance of the reactive oxygen species, because which is the correct amount of supplementation that you have to give? Do we know? No, we don't know. So the question can be yes or not. It depends on the history of the patient. So you have to see, first of all, the couple and not only the man, because this is a couple problem. And after this, all of this evaluation, you have to put together all the things that you have today available, and then you have to decide if giving the Proxeed or any other kind of supplementation.
So I would always try to measure reactive oxygen species level somehow by one of the 2 or 3 tests available, and I would always try to measure the DNA fragmentation, bearing in mind that they may not be comparable test to test, but I would advise getting familiar with a test of fragmentation, a test of reactive oxygen species, and then working out, and this isn't evidence-based, but we're not going to get the evidence unless we do it, as my friends are, and then working out how long and with how much to treat our patients. But I think ignoring all of it and not treating them, we've got to the point where that isn't an option.
Further than antioxidant, what kind of medical therapy you can suggest? Nothing, because even hormonal therapy, there is not strong evidence. So we have to keep in mind even the availability of what we have.
Good. There's a question in the middle. Yes, sir.
This is Dr. Zitawi from Jordan. I'm a urologist. My questions to Dr. Maria. Sometimes we face cases with teratospermia, patients who having 100% abnormal sperms. I don't know if you come across any beneficial medical treatment for these cases. And in cases of patients who's having varicocele, did you find the varicocele ligation is beneficial for these patients?
So yes, so when you look at the semen analysis, you have to see all the parameters. You are talking about teratospermia, so the typical and atypical forms of the sperm. So this is another parameters that we evaluated on our paper, and we see that there is a statistically significant difference even on the number of atypical forms of the sperm. So yes, I can suggest even for teratospermia to make a treatment for this. Regarding the ligation, I don't have direct experience with this, but yes, in general we can see that the ligation of the varicocele and the surgery can help even in teratospermia.
Second question, is there any age limit for the varicocele ligation, in your opinion?
This is really difficult to reply again. So I made a varicocele ligation I can say 4 months ago of a patient of 55 years old, and after ligation his wife became pregnant. So maybe I'm sure that if you make the ligation when you are 18 years old, the chance of reaching a better fertility are really good. If you do at 55 years old, is something really difficult to reach an increase. But maybe you can reach that small increase that is enough to become your wife pregnant. So why taking out the opportunity to a person of 50 years old of trying to make this kind of treatment? You can say that we have so many ligations that are not invasive, so maybe you can take in consideration.
But most of the data before, they were trying to tell that ligation after 40 years of age is very, very, very limited benefits.
Exactly what I'm telling you, that in reality, as older you are, as less you will recover the fertility. But it can happen even that treating patients with that are older, you can reach something.
Okay. A question for Dr. Genassani. Did you observe any clinical benefit in the women with PCO treated with Proxeed? Or just was a study of the hormones levels differences?
Well, clinically speaking, the study is ongoing. So these are the very first data that we have after 12 weeks of treatment. So 12 weeks are 3 months, so not enough just to get any kind of other observation at least. The study should be done over 6 up to 12 months. So we might follow at least the way of getting the menstrual cyclicity and mainly the changes that are induced on the hyperandrogenemia, if present, as well as obviously on the metabolic aspects. But the target that we are looking at, the first ending points, are the control of insulin and the metabolism. We are sure that if we are able to change or to reduce greatly, more than what we have seen in these preliminary data, the level of insulin, probably we get better results also on the reproductive aspects, which is LH, obviously, and mainly the control of androgens production from the ovaries. So we need time just to get the better results in the future.
Thank you. The second question is about the. You show the amenorrhea and the PCO and the difference in the levels of LH. And in cases of hyperprolactinemia, do you have any data about that?
Not really using compounds combined with carnitine. If you have hyperprolactinemia, you know very well that you have to keep control thyroid function and, if possible, to reduce the control of TSH. And on the other one, you need a dopaminergic compound just to control prolactin secretion. If you still have abnormality in the levels of LH, you might try the use of carnitines, but we do not have done any specific study on this.
Okay, thank you.
Good. So I'm just going to allow one more question from somebody who hasn't asked a question. There's a waving hand. I'm sorry, sir. It went up just before yours. And this has been a great meeting, actually. Wonderful talks and great quality questions from the floor. And they're coming in twos. And I'm sorry I didn't allow you a third, but I'm doing my best. But these are good questions and great answers.
Natalie Atala from UK. Endocrine question. I see quite often actually a combination, very challenging. The young women coming with oligomenorrhea or amenorrhea in the 20s, early 30s, the new lifestyle, over-exercising, professional. Of course, you start the investigations, and now I'm seeing a lot of a combination of both the hypo, and on scanning them, I can predict their ovaries look PCOS. So once we succeed in raising the gonadotrophins up, I'm ending up with the problem of the resistance of PCOS. So it's a combined condition here. Now, the supplements, my question, right, the dosage, the proportion, and what type of supplement in such cases, and do we change after we resume the increase in the LH and FSH when you start seeing them rise, which mainly I think when I tell them stop exercising, they are addictive of it and start to put on a bit of weight, but I wanted to know the role and the doses of the supplements.
Well, the problem, you know that when you have to deal with women, you are not dealing with men, which is the great difference. So you know very well that it's a tactic problem.
Yeah.
So when you have a male, you say, hey guy, you have a problem, you have to follow my ideas. For sure, the man will do everything that you are asking to do, for sure. With women, you have a little bit to be more tactic, and you have to discuss a little bit. Well, the strategy, I'm joking, the strategy is that the beginning of the story is to treat women without asking any changes in the lifestyle. The intriguing story is that all the data that I showed on the hypothalamic amenorrhea have been obtained in the first 10-12 weeks of the treatment, and all these have been the trigger so that to gain the attention of the lady on how the biology was responding to an integrative treatment without asking any lifestyle changes. And I refer in these to jogging, dieting, and being nervous, working too much. So if we are able enough to let the lady understand that even if she was not doing anything and just only the compound as integrator was working for her, probably things would be even more better if she would a little bit apply some new lifestyle regulations. Reduce the dieting, reduce the hiking or jogging, or reducing the working. So we have a first integrative approach, then we add a little bit of a neuropsychiatric strategy, which means just talking even a little bit more attentively with the patient, and then we go on treating the patients and following them, usually in our ambulatories, once every 3 months. And we have a sort of system which is discussing with a lady together with all the medical staff, which are 6 elements plus me, and this gives a little bit more stressors in the sense of I need to have a positive result to be a little bit, gifted by the fact that everyone is happy for me. So if you try to move a little bit on the neuropsychological support, you get even more results. But the administration of the integration is continued up to the moment we get at least the levels of LH high enough to suppose to have a response from the ovary, which is above 7.
Good. Thank you both very much. Now I'm going to draw this to a close. I'm going to thank both our speakers. Thank you very much, guys.